Hello, this is Professor Maha Shahin. Today's lecture is about different eye signs, particularly anterior segment of the eye signs. First, this is a case of ptosis. What is ptosis? Ptosis means dropping of the upper eyelid below its normal position. Normally, the upper eyelid covers 1/6 of the cornea, which is about 2 millimeters, as we see in the right eye of this patient. But look to the left eye. The upper eyelid covers more than half of the cornea. This is ptotic upper eyelids. Note the position of the left eyebrow. The left eyebrow is elevated by the frontalis muscle in an attempt to elevate the dropped upper eyelid. Look to the reflection of the light on the cornea of this child. In the right eye, the reflection is in the center of the pupil. In the left eye, the light reflection is seen in the temporal part of the iris near to the limbus. The eye is deviated inwards. This is convergent squint. The right eye is the fixing eye and the left eye shows convergence. In this child, the light reflection is seen on the nasal side of the right cornea. The eye is deviated outward. The light reflection is seen in the center of the left pupil. The left eye is the fixing eye and the right eye shows divergence. Do you see these raised yellow masses in the upper and lower eyelids? These are xanthelasma. They indicate raised blood lipids. The bony orbit is clearly demarcated in this patient. The eye is retracted within the orbital cavity, possibly due to atrophy of the orbital fat. This is a case of ophthalmos. To diagnose ptosis, look to the position of the upper eyelid. To diagnose enophthalmos, see if you can easily demarcate the borders of the bony orbit. Sometimes both conditions exist in the same patient. This is a case of proptosis. Proptosis is the opposite of enophthalmos. In proptosis, the eye is protruding outside the orbital cavity, possibly due to the presence of intraorbital mass or structure. The most common cause of both unilateral and bilateral ptosis is thyroid ophthalmopathy. In cases of proptosis, both lids are retracted, allowing for exposure of the sclera all around the limbus. Do you see these rounded elevations on the everted eyelid? These are conjunctival follicles. They are seen in a group of conjunctival inflammations, including trachoma and viral conjunctivitis. The conjunctiva in this slide is whitened, thickened, and scarred. This is the third stage of trachoma, the cicatricial stage. The patient is not infective in this stage. Another finding seen upon eversion of the upper eyelid is papillary conjunctivitis. The papillae are finger-like projections. And these papillae have flat tops. Most commonly seen in cases of allergic conjunctivitis. This slide shows the upper part of the cornea. The upper part of the cornea shows pannus caecus. What is pannus? Pannus means infiltration of the cornea by cells and blood vessels. And what is caecus? Caecus means dry, so this is a dry pannus. Again, this is one of the manifestations of scarred old trachoma. The patient is not infective in this stage. This eye shows trichiasis. In trichiasis, the lashes are maldirected to rub against the cornea. If they are more than 4, so this is trichiasis. Less than 4, they are just rubbing lashes. In order to detect if the lashes are rubbing against the cornea or not, try not to separate the eyelid from the eye globe with your finger. Don't put your finger on the eyelid. Otherwise, you may exert a pressure on the eyelid that draws the lashes away from the cornea. Just leave the eyelid in its position and look to the direction of the lashes. In this eye, there is grayish red fibrovascular epibulbar mass extending from the conjunctiva to the cornea. It crosses the limbus. This is pterygium. Pterygium is seen in the nasal side of the eye in most of the times. It's triangular in shape. It has to cross the limbus, and the head of the pterygium is on the cornea. Bengicula is differentiated from pterygium by the following points. First, Bengicula is yellow, as we see in this picture or in this photo, while pterygium is grayish red. The apex of the Bengicula is directed away from the limbus, while in pterygium, the apex of the pterygium is directed towards the limbus. Bengicula never crosses the limbus. Pterygium must cross the limbus. Pterygium is on the nasal side of the eye in most of the times. Bengicula may occur nasal or temporal. This is how ophthalmologists examine the eye. We use the slit lamp to produce this slit lights. Slit light A is on the cornea to examine the cornea, B on the iris, C is on the anterior lens capsule, G to examine the lens nucleus, and E examine the lens cortex. This slide shows faint opacification of the cornea. An extra light is needed to be able to detect this corneal opacity. So this is corneal nebula. This corneal opacity is more dense. It is detected within room light. No extra light is needed to be detected. This dense corneal opacity is glaucoma. Is this glaucoma adherent or non-adherent? It's non-adherent because there is no adhesion between the opacity and the underlying iris. And the regularity of the pupil confirms that this is glaucoma non-adherent. And what about this opacity? This is dense corneal opacity. The opacity is vascularized because normally blood vessels do not appear in the cornea. The opacity is adherent to the iris, dragging and distorting the pupil. So this is vascularized glaucoma adherent. Do you see these abnormal blood vessels on the iris? These are rubeosis iridis. Normally, we don't see blood vessels on the surface of the iris. And what about the black triangle in the upper part of the iris? This is a cut in the iris. This is a peripheral iridectomy. Cataract. What is cataract? Cataract means opacification of the human lens. We have four main etiological types of cataract. First, developmental cataract seen in infant and children. Second, complicated cataract, complicating systemic and local diseases and drugs. Third is traumatic cataract induced by trauma. And the most common of them is senile cataract seen in the elderly. This slide shows two of the most common morphological types of developmental cataract. Above, we can see total cataract in the right eye, and below we see the lamellar cataract with the characteristic cogwheel appearance. These forms of developmental cataract are much less common than the previous two types. Above and right, we see a small anterior polar cataract. Why it is anterior? Because it is at the same level with the iris. Below, we see pyramidal cataract. To the left, we see posterior polar cataract. And why it is posterior polar? Because it is far backwards from the iris. And using the slit lamp, we can see that it is seen with the slit on the back of the lens. So this is posterior polar cataract. Some rare forms of developmental cataract. Above and right, we see the blue dot cataract. The blue dot cataract does not affect the vision. So it is not rare to see this form of cataract in a young adult because there was no diminution of vision that drives the parent to seek earlier medical care. Bluette is the sutural cataract, causing this Y-shaped opacity of the lens. It is opacification of the sutures of the lens. To the left is the coronary cataract. There are multiple triangular opacities in the lens. The bases are directed towards the center of the lens, and they are arranged in the periphery of the lens as a crown, and hence the name the coronary cataract. Senile cataract is the most common cataract. To the right, this is the normal eye, and the pupil appears gray to black. The light is focused on the center of the retina. To the left is an eye with cataract. The pupil is grayish white due to opacity in the lens. This opacity causes dispersion of the light inside the eye, and so the blurring of vision. In senile cataract, the opacity may affect the nucleus, causing nuclear cataract, or the cortex, causing cortical cataract. Nuclear cataract has different grades. Early, the cataract is just yellow cataract. And with the progress of the cataract, there is increase in the density of the yellow color, ending in brown or black coloration of the lens. So, nuclear cataract is diagnosed by the color of the opacity. Cortical opacity is grayish-white. At first, few cortical fibers are opacified. The early opacification is triangular in shape. The opacities may be very few or multiple. They may be small or extending to the center of the pupil. This is senile incipient cataract. With the progress of the cataract, more cortical fibers are opacified. Some lenses may absorb water, so the lens gets swollen, pushing the iris forwards, and the anterior chamber becomes narrow. The absorption of water causes the lens to acquire a glistening white color. Intumescent cataract may lead to secondary glaucoma, so it is important to recognize intumescent cataract by the characteristic glistening whitish color. Then, with more opacification of the cortical fibers, the lens will pass to the mature stage when all the fibers are opacified. If not treated, it may pass to the hypermature stage. Look to the cataractous lens to the right. Do you see these multiple tiny white dots within the cataract? These dots are microcalcification. The lens is dry. The lens shrinks in size. So the anterior chamber deepens. A special type of hypermature cataract is seen to the left. The cortex is liquefied. So the nucleus drops down in this liquefied cortex. The nucleus is brown, as if it is a brown stone thrown into a white pool. Cataract is treated by cataract extraction mostly by phaco or extracapsular cataract extraction. The posterior capsule of the lens is left behind to support the inserted IOL. Unfortunately, this posterior capsule may undergo opacification, producing this white sheet seen in the right. It's seen months or years following cataract extraction. It's treated by YAG laser, producing an opening in this opacified posterior capsule, as seen in the eye to the left. There is central opening produced by YAG laser treatment for the opacified posterior capsule. How to differentiate if this is a posterior chamber IOL or anterior chamber IOL? Posterior chamber IOL is inserted in the posterior chamber behind the iris. Any IOL has two parts. The central part called the optics and two foots that help in the insertion of the IOL called haptics. These blue foot. In posterior chamber IOL, these feet are hidden behind the iris. So, this is a case of posterior chamber IOL, and the feet of the IOL or the haptics are under the iris. You will not be able to see them unless with fully dilated pupil, but the glistening appearance of the IOL is seen in the pupillary area. With multiple reflections of the light. This is anterior chamber IOL. It is inserted in the anterior chamber as its name implies. So, as you can see the whole IOL, the whole lens is seen. You can see both the optics and the haptics of the lens in front of the iris. In addition, you may detect one or two peripheral iridectomies, or maybe more. As you can see, the black triangle seen in the upper part of the eye. In rare cases, there is no IOL inserted in the eye. This condition is known as aphakia. Aphakia means an eye without a lens. The pupil is jet black in color, dark black, resembling the oil color. Sometimes you may detect peripheral iridectomy or even sector iridectomy, where the iridectomy extends to the pupillary area. And only the reflection of the light on the cornea is seen. No other reflections are detected. The third type of cataract are complicated cataract. The eye to the right shows posterior cortical cataract secondary to prolonged systemic steroid treatment. Why it is posterior cortical cataract? Because the opacity are far backwards from the iris. It's near the vitreous. The eye to the left shows complicated cataract to uveitis. Why uveitis? Can you see the pupil? The pupil is irregular, and there is adhesion between the pupillary border and the underlying cataract. This posterior synechia is responsible for the irregularity of the pupil, and the posterior synechia indicates previous attack of uveitis. So the cataract is a complication of uveitis. The eye to the right shows anterior polar cataract, and the eye to the left shows snowflake cataract complicating diabetes. Thank you and good luck.